So during the next 15 to 20 minutes, we will discuss about the definition of AKI, recognize incidence and risk factors, talk a little bit about pathophysiology and causes, briefly outline some of the causes and their management, and also to discuss the outcome of AKI in pregnancy. So how do we usually measure the renal functions in non-pregnant population routinely? In the interest of time, I will just go through. So we don't really measure the renal function in non-pregnant population. We actually estimate the renal function. So based on a marker that is cleared from the kidney, that is usually creatinine, we estimate the renal function. So there are a number of complex formulae that we use to estimate the renal function. Unfortunately, none of these formulae are validated in the pregnancy. So instead, we use serum creatinine to assess the renal function in pregnancy. So there's another marker that is used to check the renal function, that is cystatin C. However, the cystatin C is not used to assess the renal function in pregnancy. So there are a number of criteria to define AKI. Similar to that, we don't have a proper formula to assess renal function in pregnancy. Here also there is no particular criteria to assess AKI in pregnancy. So all these three criteria are acceptable, but the most common, the widely used one nowadays is KDIGO criteria. So according to the KDIGO criteria, a rise in serum creatinine by around 50% within 48 hours is more than enough to make a diagnosis of AKI. Depending on the rise and the severity of creatinine, the AKI can also be classified according to stages. If it's more than 1.5 to 2 times, it's stage 1. If it's 2 to 3 times, it's stage 2. And if it's more than 3 times, it's stage 3 AKI. Or if the creatinine goes beyond 4 in the general population, it's also still considered an AKI. Now, the problem arises when we don't have a baseline kidney function. Particularly in an otherwise presumed healthy person who got pregnant, we may not have checked the serum creatinine at the baseline. So it's usually considered that serum creatinine of 0.4 to 0.8 as the normal range for creatinine in pregnancy. So if someone is having a creatinine going beyond 0.7, that is usually considered abnormal. And anything more than 90 millimoles per liter or serum creatinine of 1 to 1.1 can be considered as an AKI in pregnancy or as abnormal for the pregnancy. Epidemiology of AKI in pregnancy. So the incidence is varying. Actually, the incidence has come down drastically over the last few years thanks to advancement in medicine and good antenatal care. It's not just the incidence that has come, but also in the past, the AKIs used to occur in the first trimester as well as in the third trimester. However, now it has been shifted largely to a problem in the third trimester. So if you look at the American data, these are results from a countrywide study. So the incidence of AKI is around 0.08% in the USA. And the risk factors, of course, the age, higher the age, it's considered at a higher risk. Presence of diabetes is a high risk for AKI, and of course, certain ethnic groups. What about the UK data? The incidence from a tertiary care referral center is around 1.4%. It appears that the incidence is high in UK compared to USA, but this is solely because that this is a referral center, and of course, they manage more higher risk pregnancies. What about the world data? The overall incidence is around 2%, and from developed countries, it's much more closer to the USA data, that is around 0.1%, and in developing economies, it's around 4%. This is actually based on a meta-analysis that had been published about 2 years ago by a Thai group. The problem here is that they have included studies over a span of 30 years. So studies that had been done as old as 30 years ago, and in the study population, only 50% had received proper antenatal care. So I'm sure the current figures would be much better, and we also must be standing much closer to developed countries. What's the incidence of dialysis in pregnancy? It's around 1 in 20,000. I'm sure someone is collecting data related to Sri Lanka and will soon be published. So what's the incidence by the trimester? As I said earlier, the incidence of AKI has shifted from first trimester to third trimester predominantly, which makes, I think, life much more easier for the obstetricians as well as the nephrologist. So what are the risk factors? Age, 2 peaks, less than 20 years and more than 35. BMI, higher the BMI, higher the risk. As the gravidity and parity increases, the risk of AKI goes up. And presence of diabetes, high blood pressure, HIV and CKD increases the risk of AKI. Pathophysiology and causes, we have already discussed the physiology, so we will just directly go into the pathology. It's not uncommon to classify kidney disease even in non-pregnant population as pre-renal, renal and post-renal. The pre-renal causes are very much similar to the plumbing work, where there is a motor or the pump and then there is the piping. If there's a pump failure, if the heart is not working, then that could result in an AKI. If there's a piping failure, that is either abnormal dilatation of the pipes or abnormal constriction of the pipe, then that can result in an AKI. For an example, in sepsis, there may be abnormal dilatation of the pumps, or else in certain drugs can cause abnormal constriction of the pump. Both can result in AKI. The post-renal causes, again similar to plumbing work, there are pipes and reservoir tank. If there is any damage to pipes, that can result in AKI. If there's any damage to reservoir tank, that also can result in AKI. So the pipes can get blocked either because of the uterus or because of the stones, and the reservoir tank can get damaged either with iatrogenic or spontaneous deliveries. So then comes the most complex part, that's the factory. Of course, there are different compartments in the factory. The glomerular compartment, the interstitium, the tubules, the vascular compartment, etc. So if the glomeruli are affected, it can result in glomerulonephritis. If the interstitium, then it may be because of the sepsis or infections or drugs that can result in interstitial nephritis. The tubules can get affected either by prolonged ischemia or toxins. Vessels can get affected. And then the tubules can have like certain toxins getting deposited, as in case of the acute fatty liver of pregnancy, or else getting blocked by the thrombi in case of antiphospholipid syndrome. Causes of AKI can also be classified according to the trimester. The first trimester causes are more likely to be volume related, and then as the pregnancy progresses, 20 weeks sets in, the preeclampsia comes and more complicated UTI comes in. Towards the latter part of the pregnancy, more pregnancy-specific causes such as acute fatty liver, thrombotic TTP, and atypical HUS coming in. Lupus nephritis, although lupus can relapse during the pregnancy, the nephritis is more likely to relapse postpartum. Then the drugs also can come into play, particularly postpartum. So if you look at the causes, incidence of different causes causing AKI, as you can see, more pregnancy-specific causes are nowadays contributing to AKI. So that's the reason why we see more AKIs towards the latter part of the pregnancy. And what's the risk by the cause? So acute fatty liver seems to be the highest risk that is posing for an AKI. Then comes the respiratory problems. It may be respiratory tract infections or respiratory failure due to other causes. What about the hypertensive disorders in pregnancy? Across many studies, the incidence is around 15%. From now onwards, I will briefly discuss several causes. So sepsis, severe sepsis, according to the UK data, is around 5 per 10,000, and around 20% will experience shock and 1.5% death. E. coli is the commonest organism. Respiratory tract infections can be the killer. UTIs, as discussed earlier, can progress from pyelonephritis to severe sepsis. Acute gastroenteritis, although common, less likely to cause significant severe sepsis. Drugs and AKI, we have to be cautious with the analgesia in the postpartum period. Antibiotics, we have to choose wisely or monitor renal functions. Magnesium sulfate, although that itself cannot cause AKI in pregnancy, we have to be cautious with magnesium sulfate in renal impairment because magnesium is excreted in the kidney. So magnesium toxicity is more common in the presence of renal impairment. Post-transplant meds, tacrolimus, we should aim for a lower limit of the trough level as nephrologists, otherwise the risk of AKI is high. And anticoagulants would need dose adjustment if there is renal impairment. Toxins, Now, international literature does not talk much about toxins, but as practicing nephrologists, we see these problems more in Sri Lanka. It could be just severe paracetamol poisoning or the detergent poisoning, particularly in the southern part of the country. 6 months ago, we had a patient with Prince poisoning who almost had a cardiac arrest, but luckily the baby and the mother both survived. The tropical fruits like starfruit and billing also can cause AKIs. Snake bites can cause AKIs, and we should not hesitate to give AVS in pregnancy. So the de novo glomerulonephritis, most of the glomerulonephritis can be managed conservatively, but important things would be SLE and rapidly progressive glomerulonephritis. What about the pre-existing kidney disease? So here the problem would be differentiating from AKI as compared to the progression of kidney disease or as the superimposed preeclampsia. So as we know, if we start at 78, we would end up by the middle of the pregnancy around 58, and towards the end of the pregnancy, we would come back to or go beyond 78 millimoles to around 84. If we start at 240, then again we should drop to around 150 by the middle, and then we will go back to little beyond 250 by the end of the pregnancy. If our creatinine follows this curve, then of course that's okay, but if there is a rise, then we will have to think whether this is AKI or whether this is progression. If there's a clear-cut acute precipitant, and if there's a precipitous reduction in urine output, that is more likely to be an AKI. If your placental growth factor and the placental blood flow is affected, then it's more likely to be superimposed preeclampsia. Here again, we have to be mindful that placental growth factor is excreted in the kidney, so the target levels should be higher compared to normal renal function. Urinary tract obstruction, physiological in more than 60 to 90% of cases, as we learned earlier, more common in the right side, and the AP diameter, majority will have less than 15 millimeters. And the risk factors are the single kidneys, the transplanted kidneys, the polyhydramnios, and multiple pregnancies. Urolithiasis, as common as 1 in 200 to 1 in 1500, 75% is calcium phosphate as opposed to calcium oxalate in the rest of the outside the pregnancy. Ultrasound we can use, but may not delineate the stones. X-ray, KUB, or low-dose CT can be used. We can also use MRI, but mind that the MRI is not going to reveal the calculi, it will just appear as a filling defect. Most of the time can be managed conservatively. If not, stenting or PCN can be done, but the medical management can also be done. Tamsulosin is not contraindicated in pregnancy. If there is superimposed infection, of course the prompt decompression is required. Bladder injury, rare, early recognition and repair is the most important thing. So the clinical presentation would vary. If there are symptoms and signs of underlying infection, underlying cause, and the symptoms and signs of related to AKI would be there. So the diagnosis, thorough history and examination, lab test according to the GDs, and the imaging studies. Management, the initial management, monitoring, treatment of specific causes, and the collaboration with other teams, and of course the role of the nursing care. If the care bundles are the fashion nowadays, and of course seems to be working, if there is creatinine rise more than 90, then we should start thinking, okay, this is an AKI, and then the AKI care bundle should start. So we should check the physiological observations, assess history, and if we deemed hypovolemic, should resuscitate with the fluid. We should start monitoring, do a blood gas, check lactate, and also have a proper fluid balance chart. And the investigations based on the DTs. Volume overload is not uncommon. We have to think about when we're giving IV fluids, the nutrition, antibiotics, inotropes, all can cause AKI. We can use diuretics. IV furosemide can be used, but thiazide diuretics are not usually indicated in the pregnancy. Most common electrolyte disturbance is hyperkalemia. We have to be managed medically. If not, we can go ahead with dialysis. Metabolic acidosis can be managed with bicarbonate. If not responding, dialysis. Anemia is not uncommon even in AKI. We might have to go ahead with blood transfusion. Other aspects of management include nutrition, psychological support, and fetal monitoring. Indications for dialysis, similar to rest of the pregnancy, but most important thing, urea target are less. Urea of 20 would be an ideal target to go ahead with dialysis. Outcomes, maternal outcomes, cesarean, higher rate of cesarean delivery, higher rates of bleeding, and higher rates of death. Longer ICU stay, more healthcare cost. Fetal, higher risk of stillbirth or perinatal death. Lower gestational age, lower birth weight. Kidney outcomes, there's a sparsity of long-term outcome studies, but those who need dialysis will end up being end-stage at a rate of around 2.5%. Prevention, good pre-pregnancy counseling, good antenatal care, aspirin where indicated, plasma exchange where indicated, anticoagulation where indicated, prophylactic antibiotics where and when indicated are important. We need to avoid nephrotoxics, recognize the early stages, and liaise with the nephrology team. What about the outcomes of patient who has had AKI before getting pregnant? So they are also at a higher risk of preeclampsia and SGAs. What about those who have had hypertension and not had AKI? They are also at a higher risk of AKI, even 90 days after the delivery. So we'll leave the questions to the last. Summary, spot the AKI, involve nephrologist.